Kena notice. First, must make sure patient kan dia ada some vision. At least lah. At least have some vision. Let's say the patient is worse than hand movement. Macam mana you nak check? Let's say the patient PL lah. PL perception of light. Okay. Tak ada vision ataupun PL nak check macam mana kan? So at least there are some vision. Number one So nak check macam mana? Tutup satu mata. Okay, ini berapa? One. Okay, tukar mata. Tukar mata.
Oh, tukar mata.
Ini
Two.
Okay, enough. You tak payah a very good vision, no need. You just need the patient has some vision and you can follow you. Okay. After that, you gonna make sure patient head no movement only eye movement. So bagi tahu patient, kepala jangan gerak, hanya mata gerak sahaja. Okay. Lepas tu ada dua benda patient kena bagi tahu you masa examination tu. Jadi nanti masa saya check, kalau nampak dua ataupun sakit, encik bagi tahu. Okay. Nampak dua means there is diplopia lah. Okay, there is diplopia. If sakit or possibly the patient have, for example, like thyroid eye disease in an active phase, for example, then they will have eye movement on. They will have eye pen on movement. Or, for example, there is a retrobulbar optic neuritis. Okay, the optic nerve is inflamed. So when there is eye movement, the optic nerve being stretched. So when is a meninges, so meninges being stretched, painful lah. Okay. So that's how you check vision Okay, tutup mata. Nampak kan? Satu. Okay, tukar mata. Okay, ni. Nampak okay. So we start Encik, kepala jangan gerak, mata ikut ini sahaja Kalau nampak dua ataupun sakit bagi tahu Okay, so we start. We start with primary gaze first. Primary movement first. Primary movement is horizontal first So you start from here. Everything start from center. Okay Here. Okay, you look at the eye movement of both eyes Your movement is parabolic. See, our eyeball is rotating not move left right. So you have to move according to the movement of the eye. So the eyeball is rotating, so you follow Follow, you have follow to the end the end, so that you really sure whether there is any limitation of the movement or not. Okay, if you come here not full yet, but you have to come here. Then you are sure it is full. Okay, so from here until the end, look for any limitation of both eye, either eye, or any nystagmus. Okay, or when you're doing, you have to tell the patient nampak dua or sakit Okay, when you finish here, come back to the center, change hand, come here. Okay. Okay, finish the horizontal movement first. After that, move up. Move up You see my movement is also like this. Okay, parabolic. Okay, come back to the center, go to the diagonal. Okay, go to the diagonal, come back to the center, go to the diagonal. Okay, boleh. Now we finish the horizontal and up. And then what we will do, you have to depress. Depression. Okay, depress come down. Look for the movement of eyelid as well. Because you want to look for any lid lag. Okay. After coming down, tell the patient, sorry encik, saya akan angkat kelopak mata sikit. Okay. Now you are sure whether the movement is full or not. Okay. So you continue move back to center, come here, move back to center, come here. Okay. Boleh Gaze number one, center. From center, you know if there is any deviation or not. Okay, so on primary gaze, it is orthophoric. Orthophoric means at the center, straight, no deviation. Okay, so on primary gaze is orthophoric. So on horizontal gaze, okay, it is full. Okay, up gaze, okay, level elevation, dextral elevation. Level is L, dextral is right. Okay, down gaze. On depression, angkat kelopak mata, keep on elevating come back to center, dextral, depression, center, level depression, center. Okay, full. Okay No problem, no question, very easy only. Levo and dextro. Dextrocardia kan? Dextrocardia means to the right. So it's dextro elevation, dextro depression. Okay?
Yang kita elevate the eyelid just masa
Down gaze.
down gaze.
After down gaze, because when down gaze you are looking for eyelid.
Okay.
You tak elevate, you tak tahu eye movement macam mana.
Okay.
After coming down, keep elevate. Then you know whether the movement is full or not.
Okay.
Then continue to elevate here and here.
Dextro, level depression pun still kena elevate lah. Okay.
Keep on elevate. Basically for down gaze you have to elevate to see the movement of the eyeball whether it's full or not. Okay boleh. Very simple. Nak buat hatch boleh tak? Boleh. Tapi in opta we don't practice that because it's actually not as full as the line gazes. Yeah. How you do hatch? Censor now. Basically the left so it means the abduction is not full. You know adduction and abduction, right? Adduct is coming in, abduct is going out. So you see the hatch actually is not full one. You still can see the eyeball. I mean the sclera.
Sclera show.
Yes. Okay, come here. Up, down. Okay. In order to achieve a full movement, you have to go parabolic to the end. Okay. UM any question? Very easy. UM is the easiest one. No problem at all. Yeah. No problem. No need to close lah. Okay. Boleh? UM any question?
Yang kita nak fix center tu, fix patient mula-mula untuk central.
Tak payah tengok depan. Tengok depan. Tengok depan.
Okay.
If not you get the target because you're using target now. Preferably the target is red color or colorful one Okay. Preferably
Okay.
and not too big. You have to have a focus point.
Okay.
That is a good target. Okay. Let's say you are having a pen doesn't matter. This is a red color cap. Then okay Okay. You have any question? Faham Okay. After that we go to confrontation. Confrontation basically you are checking for visual field.
Visual field.
In examination we check confrontation. In test investigation we do
HVF.
yes HVF. Stand for apa?
Topo.
Humphrey visual field. Bukan topo. Okay. Topo is cornea, curvature. Okay. Humphrey visual field that is investigation. Not your part, no need. That one is leave to us. Okay. You just have to do confrontation in the clinic. Who need to do confrontation? Who need to do confrontation? For example, patient.
Semalam patient post trauma.
Yes, post trauma. For example, there's a bleed in the brain. It cause a. For example, here so it cause a.
Hemianopia.
Hemianopia. Homonymous hemianopia. Okay. Any lesion in the supracella, for example, craniopharyngioma, pituitary edema, yes. Okay. Anything involved the optic horizon is caused by temporal hemianopia. Okay. Totally involve one eye. For example, the optic nerve here involved totally. So it's one eye totally blind. Okay. If glaucoma, what will happen? In an advanced glaucoma, what the patient will have in the visual field?
Nasal.
Advanced. Nasal step is early.
Okay.
Advanced.
Total blindness.
Tunnel vision.
Tunnel.
Okay, because usually glaucoma, the visual field is from the peripheral involved to the center. So initially, the patient had the peripheral involvement. So most of the time, if the IOP is not too high, the patient will not notice at all. When they notice, it's very late and severe already, because the visual field become very constricted, and even more become tunnel vision. Okay. So how we check confrontation? Same. We have to make sure patient have some vision. If no vision, cannot check. For example, PL, how you want to check? Okay. So same, do like that just now. Ini. Okay. Tukar mata. Okay. Good. When we have some vision, then only we can check. Okay. Then here you must sini sikit. Nanti tanggal. Okay. After that, you ask patient close one eye. Tutup satu mata. Okay. We have to divide our visual field into 3 parts: center, mid periphery, and periphery.
Periphery.
Okay. So when for center, pinjam tak? Dah lukis. Boleh lukis. So when we want to draw visual field, right? Okay. Center, mid periphery, and periphery. So you have to draw lah. Two, sorry. Like this. Okay. Which one is right? Which one is left?
This one is dia terbalik.
Yes.
Left, right.
Terbalik. Okay. Left eye is here, right eye is here. However, a lot of people mistaken. So what you have to do, you label. You have to label. Okay. You have to label. Okay. When you interpret the HVF, you also have to put like this. Okay. Okay. So when we want to access the center, ask me to close one eye. Okay. Center is by face recognition. Okay. Look at my eyes or look at my nose. Okay. Either one okay. Okay. Encik tengok sini. Muka saya penuh, ada hilang mana-mana? Tak ada. Okay. So central vision okay. Okay. After that, you have to close one eye. You boleh wing. Wing. Boleh wing. Boleh wing tak boleh wing susah sikit.
Boleh kejap je.
Sebelah sini tak boleh.
Kalau tak boleh wing dia susah sikit.
Kena pakai eye occluder.
Okay. Then you wing his right eye, your left eye Okay. Wing Okay. Look at each other eye. The distance has to be same distance of your hand. Okay. From mid periphery, you use counting finger. Okay. Berapa jari? 2. Okay. 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 Here you have to be careful because maybe you block by his hand. Okay. After that, we go periphery. At periphery, don't do counting finger. What you do is
Hand movement.
Okay. When you do hand movement, make sure it is just your
Finger.
finger ni. No need. Not like that. Like that, everybody can see lah. Okay. Okay, each other. At the most, outermost, you move a bit. Nampak kan? Nampak gerak Nampak gerak. Sini. Nampak. Okay. Okay lah.
Letak how do we estimate yang mid periphery.
Your hand.
Yang ni kalau
You stretch lah.
Okay, sini stress sini, lepas tu outermost.
Outermost is diagonal. Everything is diagonal one.
Okay, sini.
Because for quadrant, everything is diagonal. Okay.
Okay.
Same change the other eye. Okay. Encik tukar tangan. Okay. Tengok sini. Muka saya ada hilang mana-mana tak? Tak ada Okay You wing. Look at it. Okay. Ini berapa jari?
2. 1. 2.
Okay, good. Nampak ke?
Nampak.
Sini.
Nampak.
Sini.
Nampak.
Okay.
Nampak.
Kenapa you have to wing? Why you have to wing?
Same visual field, same
No, you have to
limitation.
wing because it's easier for you to access. For example here, I have to do like this.
Oh.
Okay. If I want to, let's say you tutup mata, tutup ni Okay. If you don't want to cross with this hand, if you cannot wing okay, how you want to do like this? Cannot. So you have to wing.
To free yourself.
You have to free yourself. That's why you have to wing. Okay. As the same as fundoscopy also. If you cannot wing, it's susah a bit. Okay, so must be able to wing. Okay.
Kena beli eye
Muscle
occluder.
is something can be practice on.
Exercise.
But no, muscle is something can practice on. Okay. So after that, what we do? We finish confrontation. What we do? We do
Confrontation.
refine. When you want to refine, you use white color. Pinjam tu, ni bagus. Okay. White color pin kan masa kita undergrad ada white pin and red pin kan. That is when you have to use When you want to refine, same. Tutup satu mata, you wing. Look at each other eye. From the outermost diagonal you move in. Okay, encik encik tengok sini nanti saya akan gerak daripada tepi masuk ke dalam Okay, kalau tak nampak bagi tahu Okay. Nampak kan? Nampak. When you reach the central line, cross a little bit. Okay Then here. Okay, nampak nampak central line cross a little bit now is the importance of being able to wing. Okay, free. Okay, nampak. Here be careful a bit Okay. Nampak Okay. Then you change hand. Okay. Tengok sini Okay, nampak Nampak central cross a bit. Here nampak. Okay. Central cross a bit. Okay, here. Central cross a bit. Yeah. Okay, like this. That is refine. Why you have to refine? Because initially, in each of the quadrant, we test at one spot only. Okay, test at one spot now. For example, I test at this spot. You can see. Okay, but then when I refine, maybe this part you cannot see.
Oh.
So you roughly know the extent of the visual field defect. Okay. Okay. Tapi lagi visual field confrontation. So what you have to do next? You have to
Right.
do a blind spot with red pin. But kita tak apa. What is the anatomical application of a blind spot? What does a blind spot means in terms of anatomy?
Image tu jatuh dekat apa nama dia?
Basically, blind spot is what? In terms of anatomy, blind spot of course something a visual field that we cannot see. But I mean, what gives rise to the blind spot? What structure gives rise to the blind spot?
Bukan market. Optic disc.
Yes, optic disc. Because there is no new photoreceptor there. Okay, it's the convergence of all the optic nerve fibers. Okay, not retinal nerve fibers. Okay, there is no any photoreceptor there. Basically, it cannot receive anything. It cannot perceive anything. So it becomes a blind spot. Okay, basically, the blind spot is because of optic disc. Okay, so where is the blind spot located? Here, where? It is equivalent to the optic disc lah.
Peripheral.
Okay, basically it's about 15 to 18 degrees away from the central line. Okay, so you have to agak-agak know where is it. Itu satu mata. Look at each other eye. Then you have to wink. You have to check one eye by one eye. Okay, it's a horizontal movement. No need up, down, diagonal. No need. Horizontal movement from the outermost. Sentuh tengok ni Okay, move in. Nampak kan? Nampak. Hilang kan? Okay, muncul balik kan? So when patient cannot see, you also cannot see. When he can see again, you also have to see again. So first of all, you have to make sure your blind spot is normal lah. Okay, same. Okay, kita sini. Daripada outermost move in, nampak kan? Nampak. Hilang. Sini kan? Then ada dah kan? Okay. Horizontal. Why we have to use a white pin? White pin for visual field. White pin. Visual field tak boleh guna red. Why have to use a white?
Some sort of natural.
Why? Because of photoreceptor. We have two types of photoreceptor. We have cones and rods. Okay. When it is cone C, cone C. It means it's at the center and for color. Okay. Yeah, higher resolution. Okay. So only the macula will have photoreceptor cones. Okay. And even more in the fovea. Okay, that's why in the central vision you are better than your peripheral. You also can try lah. You try to see your central vision. Is it far more better than your peripheral? At the peripheral, it can help you to alert there is something there, but maybe you cannot recognize what is that. Or if you can recognize, also not clear. That is because your photoreceptor is more concentrated, and the photoreceptor consists in your macula and especially the fovea. The macula and fovea, the visual field is very small only. Okay. So at the periphery, we don't need you to know what is that. You just have to be able to recognize something is there. Okay. So at the periphery, you only have photoreceptor rod, which is not so sensitive to all the color or whatever. So it's not fair if you use a red color. So you have to use a white color. Okay. You just need to know it is there. Don't need to know how clear it is. Okay. Visual field is to test how white you can see, not how clear you can see. Okay. Boleh ya? Confrontation, any question? Any question for confrontation?
Question untuk yang central tu just nampak muka saya whole
Muka
lah.
saja, muka
Okay.
saja, face ni. Any missing parts? Okay. Let's say the patient have a hemianopia lah, so half of it you cannot see lah, half of it.
No.
Okay. So how we document is basically, let's say the patient has a hemianopia, has a left homonymous hemianopia. So you can either document like this, or you lorate on it, either one. Okay, like this lah, right left homonymous hemianopia. Okay, so I simplify. So let's say it's like this. So this bitemporal hemianopia. Okay, I simplify. So this is left superior quadrantopia. Okay,
Oh, kuadran
quadrant saja. Okay, so what is solution? This is in the right temporal. Often a lot of things is the balik one. Left will be at the right, right will be at the left. The parietal lobe, which is located above the temporal lobe, is in charge of the visual field at the inferior. Okay, that's why a temporal lobe that has a problem, the visual field defect will be at the superior, and of course the opposite direction. Okay, left is right, right is left, up is down. Okay, boleh ya? Confrontation?
Okay.
Boleh. Now we go to pupillary examination. Okay, when you want to check pupil, first you must make sure patient is looking far. Why?
To relax.
What
Pupil
mechanism
dilatation. Pupil dilatation.
Any mechanism we want to avoid or prevent?
Pupil constriction.
Yes, why?
Because we want to check for the reactivity of the pupil. So
No. What is the mechanism we want to prevent?
accommodation.
Yes, accommodation. We don't want the patient to accommodate. Accommodation means the patient is looking at something near. Okay, they're focusing on something near. Okay, when it's focusing on something near, it's called accommodation, and there are a few mechanisms inside. There are a few things that happen inside. One of them is pupil constriction, pupillary constriction. Meiosis. Dua lagi apa? When you're focusing on something near, what will happen to our eyes? Yes, convergence. One more is what? Meiosis, convergence, and the lens become thicker. Our lens are become thicker, the better part, because they want to increase the focusing power. Okay, that's why when the patient started to have cataract, okay, there's cataract or getting old the ability of the lens flexibility is reduced. The zonules is weaker. Okay, not the zonules. The stereo body is not so strong as last time. So they have lost the ability to change the focusing power of the lens. That's why that's why everybody after 45 or 50 they started to have presbyopia, unable to see something near. This is because they cannot change the lens refractive power anymore. Okay. So that was okay. Ask the patient to look far. This is very important. Okay. Ask the patient to look far. Number one, you have to know the size and shape of the patient's pupil. Just enough to see from interior, just enough to see the size and shape of the pupil. No need to shine directly. Okay, just enough to see the size and shape. Okay, so the pupil is 3 mm round for both eye. Okay, reactive or not, we check with direct. Okay, what is direct? Directly shine on it, but not like this. You have to come from the side. Same, ask the patient to look far, all the way look far. Okay, from the side. Okay, move in, shine on it. Not directly here because you don't want to induce meiosis. Sorry, you don't want to induce accommodation. From the side and very uncomfortable. Come here, constrict. Okay, here, constrict. Okay lah. So direct pupillary response or reflex is normal for both eye. Okay. After that, another torchlight. So we use this one. Supposedly have to use torchlight one. Okay. Then after that, what we do? Direct we finish already.
Indirect.
Third step is indirect. Kenapa ada indirect?
Untuk dia punya
Why we have indirect?
afferent and efferent.
Oh yes. Why?
So,
Yeah, correct. You are right. But why?
so apa tu, with the apa macam Algar Robertson pupils, if the afferent nerve,
Because
if we shine from the efferent nerve still intact, okay, salah.
why we have a why we can access the indirect? That is because one afferent, when you reach the midbrain, it will give rise to two efferent. Stimulation of one eye go to the midbrain, you give rise to two efferent pathway and supply both eye. So you shine on one eye, both eye will constrict. That is because of the two efferent pathway. Okay. So when you want to assess indirect or consensual, this one just enough to see the size and shape. Okay. If I want to check the left eye, I don't need to see on the left eye. I only see the right eye. Okay. So see, constrict. Okay. So you see this one, usually you use a weaker one, just enough to see the size and shape. Nampak kan? Can you see the size and shape? So I shine on the left eye. The right eye is constrict. Okay. So I change to the other eye. Just enough for me to see the size and shape. Okay. Come here. Can you see? There's a further constriction of the left eye pupil. You see? Can you see that? Yes. It's because the consensual or indirect is normal. Okay. After that, what we do? Yes, RIPD. Okay, we do RIPD. Too far. Okay. RIPD is relative afferent pupillary defect. When there's a word relative or relative, whatever how you pronounce it, what does it mean? It's a comparison. There must be a discrepancy of optic nerve function between both eyes. Then only you can get the response. If both eyes are totally normal, no problem, no response at all. Okay, if it is equally damaged, then no response at all. Suppose it's like that. Okay. See, constrict, constrict, constrict means normal. If you get dilate, is normal. Okay, you only need to do 3 times. Okay, first you do a direct line reflex to the right eye. You are giving the stimulus. Stimulus to which eye actually? The right eye, but actually both eye will constrict. Okay, so both eye will constrict. When you come here, if still constrict, it means in compared to the right eye, left eye is either normal or better. Okay, it cannot be worse because it constrict.
Rapid.
Because when we directly shine the right eye in the first step, you cannot say anything because you are not comparing. Okay, when you move to the left, then only you start to compare. You start to compare the left eye function to the right. Okay, so when you shine here, you stimulate both eye to constrict. You come here, here further constrict means good. In compared to the right eye, left eye is either equally good or better. You don't know how good is the function of right eye, you don't know yet because you're not yet compared to the left. So you have to do the third step. Third step is you come back here. Okay, so in compared to the left eye, Either is better than the left eye or equally good. So when I do the 3 step, both eye also constrict all the time. It means both eye are same, good, no RIPD. Okay. Let's say I do here, constrict, dilate, constrict. Which one is the problematic one?
The dilate.
Left eye. Whenever it dilate, it means something wrong there. Okay. Constrict, dilate. Right eye is dilated. It's abnormal. Okay. Initially, I try constrict because I never compare to anybody. Okay. Even if let's say 50% of the optic nerve function left, you also constrict. Okay. Of course, sometimes RIPD will terus become positive. Okay. But there's still scenario where when there are still some optic nerve function, you try on it with a strong light, it will still constrict. But it just tell you direct reflex is normal, but not yet compared to anybody. Okay, so you just remember, you shine on it, it dilate is something wrong. Okay, constrict, dilate, constrict, left eye RIPD positive. Constrict, dilate, constrict, dilate, right eye RIPD positive. When you want to swing, you have to do slowly. Okay, not like this. No. Shine on it, give some times, move here. Give some times, move here. Okay? Can? Okay, boleh.
Okay.
Very easy ni. Just the interpretation sometimes go haywire.
Betul, even kalau kita take sometimes untuk swing tu, pupils tu tak sempat dilate lagi lah.
Tak sempat. It will dilate.
It will dilate.
It will dilate.
Oh,
It will
just
dilate.
that.
What you want to see is whether there is further constriction or dilate terus.
Oh.
You cannot do fast one. No. Take some time. Okay. Slowly do. Okay, but not too slow lah.
Further constriction means in comparison to the.
Because you know why or not? When you immediately remove, you will start to dilate a bit.
A bit only. Okay.
Because the light response is no longer there, you will immediately remove. Okay. Immediately dilate a little bit. Okay. But not to the extent of in a RIPD positive case lah. If in an RIPD positive case, you shine on it. Depends on which stage it is. Sometimes straight away dilate, sometimes stall then dilate. There are 5 stages of RIPD. Okay. Different stages have different response. Okay. Okay,
Okay.
Boleh? Ocular examination. Faham? Ada warnanya?
Faham nak interpret tu.
Maksudnya interpret itu susah. Let's say the patient have traumatic mydriasis. The pupil already become big. How you want to know it is just traumatic mydriasis or it is traumatic optic neuropathy? One is involved of the nerve, another is just a pupil only. One need treatment, another one no need treatment. For example, a patient post-trauma. I think sometimes in KK also we have patient post-trauma one. Okay. Now you check the patient, you see, hey, this pupil dilated already. How you want to know it is just the pupil that rosa, which is the traumatic mydriasis, or is traumatic optic neuropathy, the optic nerve that rosa. How do you want to know that? Now, let's say right eye dilated already. Not necessary.
Indirect.
Indirect pun this eye dilated lah.
Optic neuritis ataupun just the trauma.
How we want to do indirect?
It's like on the normal side. Lepas tu, kalau kita yang tak normal tu.
If I have the normal like normal one you try is the dilate lah. So you constrict.
Yes,
You constrict lah. Then
Tapi
some
kalau yang-
now right eye is dilated. How you want to check?
Fix dilated ke ni?
Now it's dilated. How you want to know it is RIPD positive or not? How you want to know the optic nerve function is okay? How you want to know it's just a traumatic mydriasis but not a TON, a traumatic optic neuropathy?
Kita shine dekat
You
sini.
nak buat RIPD tak boleh ni.
Kita shine on the affected, the dilated eyes, and then look for the constriction on the Left eye.
Can do that, but that is not because you can do that. Surely you can do that, but not full. Not okay. Let's say right eye is dilated lah. You don't know the function of the right eye, so you shine on the left. You shine here, it constrict. Okay, but how do you know when it compares to the left eye, the right eye is not abnormal? Because this light is very weak, just enough for you to see. Now it's a normal size. I shine on this, it constrict, but you are not sure. You are not sure yet. When compared to the left, the right eye okay or not?
Shine with the same.
Now you shine on this, it's a weak light, not inducing meiosis much. You shine on the right, it constrict. It means there are still some function, but how much of the function left in compared to the left, you're not sure. How you want to do that? There is a time when you need to combine indirect with the RIPD. Okay, so you like this. Basically, it's an extra step only. Same, you shine just enough for you to see the size and shape. Okay. Now you do RIPD. You shine on this, constrict. Can you see constriction? Okay. We imagine this is dilated. Okay, shine on this. Okay, constrict. You swing here lah. If it still constrict means no RIPD. Okay. Basically, it's an extra step only.
Straight. And then
Okay, now this is for you to recognize the size and shape of the patient. Okay, I shine on this. I inducing left eye constriction. Okay, if I shine here, here also constrict. I can see my because of this light. Okay, I don't want to see this eye. I don't want. I just shine on it. All the while I'm focusing on the response of this eye, on the left one. Okay, now I'm stimulating this to constrict. Okay, I'm stimulating again. Stimulating. Okay, then I shine here. I'm also shine here.
Focusing on.
I'm inducing here. If the response that if the stimulus they receive is the same, so this eye will still constrict. Okay.
Okay.
Let's say this one is not enough, not strong enough to induce constriction one. It's just for you to
See.
observe, to see. Okay. Let's say, okay, I shine on this, it constrict. I come here, it dilate. So what does it tell you?
Tak ada ni lah, tak intact lah. Is the
Which one is not intact?
this one. Sebab dia tak dapat receiver.
Yes.
Tak receive.
Yes, very good. Okay. You remember what I said? This line is just enough for you to see or observe the size and shape of the pupil. Not strong enough to induce meiosis. If you use a very strong light, all the time shining on this, no need to compare lah, because the eye is keep on in a meiosis. Okay, remember this one cannot be too strong. Just enough for you to see the size and shape. You shine on this, you are giving input to the left eye. Okay, now left eye remember already. Okay, how strong it is. Okay, I come here. If the left eye still constrict, then okay lah. Means right eye also perceive the same stimulus, same intensity of the stimulus. However, when I give this intensity, I come here, the intensity perceived is less. So why do I still need to constrict so much? I dilate. Okay, boleh. It's just an extra step only. Boleh ah? Faham? Any question you wanna ask? So there are 4 steps. KIV plus 1. If there is traumatic, if there is a dilated pupil.
And ISO.
If that one, then you need to check. For example, trauma, whatever lah. Okay. If no, then the 4 step enough already. First, look at the size and shape. Second, direct. Third, indirect. Fourth, RIPD. Okay. KIV add on one more. If you see one eye is dilated. Okay. Okay ah? Boleh faham? Any question? Ada ah? Then we go to fundoscopy.
The most
Fundoscopy, actually this one is not so proper one. Usually we use what? The really arc one. Never mind. Okay.
Buka lah.
This situ. Boleh buka dulu
Nak
nanti.
tengok ni.
Nanti saya masa nak tunjuk baru tutup. Okay. This is our ophthalmoscope. We have two sides. Okay, you see. This is your examiner side. This is patient side. Examiner side is here got a brow rest. The name is brow rest. Not necessarily you put on the brow and rest there lah. Okay. Then you have this thing. This is called viewing aperture. Okay. Viewing aperture for you to see through one. Okay. And then you have this indicator here. Indicator. This is the indication of the dioptic power. Okay. You have a rheostat. Rheostat is to adjust on and off and also adjust the brightness. Okay. So how you want to hold? You have to hold like this, keeping your index finger free. Okay. Then you have the side dialer and front dialer. Side dialer and front dialer. Okay. Side dialer is to change the refractive power here. Okay, you see. Okay. See. Okay. Red is myopic, like most of us lah. Okay. Yellow is neutral, zero, plano. Green is hyperopic. Okay. Most of the ophthalmoscope is the same one. Just the design of this is different. Okay. Here you see this one, this is the light beam. Okay. Then you see a smaller light beam. Okay. Smaller, larger. Okay. Then this is half light. This is blue, cobalt blue light. This is grid. Okay. Can you see the grid? Okay. Grid can you see that? Nampak? Nampak? Ada grid. Okay. This is slit. Okay. Usually lah kalau kita guna BD arc kan, dia ada 3 size, 3 size beam to select. Okay. As a rough guide, the largest beam, tapi kita tak ada kan largest beam. Ini ada 2 je. Is for a dilated pupil. Either is traumatically dilated or whatever reason dilated, or you use a dilating drop dilated. Okay, cannot constrict it. Then you use the largest one. Okay, regardless is in a dark room or bright room, doesn't matter because it's dilated, pharmacological dilated. Okay, if you are checking the patient, you do not have any dilating drop. Okay, you don't have any dilating drop. The pupil is not dilated. Okay, you are checking the patient in a dark room, dark environment. So by default, physiology, normal physiology, in dark room, our pupil will dilate. So you use a medium beam. Tapi ini tak ada lah. Okay, you use a medium beam. In a bright, well lit room, you use the smallest beam. Okay, this is a rough guide. Of course, you have to adjust according to the pupil size of the patient. Okay, there was some variation sometimes lah. Okay, why we want to do that? Basically, you just want the light beam that able to pass through the pupil only. If there is extra than that, you instill further miosis. You don't want that. Okay, and discomfort. So you just want the size to be
Just enough.
just enough. Okay. More than that, you induce further constriction. So it's not good. Okay. Boleh buka ni. Cobalt blue light, of course, is to see any corneal abrasion. For example, you have to use together with a fluorescent strip, fluorescent stain. Okay. Then the grid is to measure. No need . Then the slit. When do we use the slit? Because this thing is a one eye only. You use with one eye only. Okay. So you do not have a 3D image. In order to have 3D image, you need to have a stereopsis. Stereopsis is a binocular single vision. Okay. It means you have to use both eyes. One eye only, you cannot estimate how deep it is. Okay. So when we check with one eye, there is no stereopsis. Let's say this is the fundus. Okay, this is the optic disc, this is the vessels. Okay, this is the macula. Let's say you see a lesion here. Because we are checking with one eye, there is no stereopsis. How do you know whether it's elevated or it's flat? Okay. How do you know that? You use a slit. Let's say this is flat. So when you move past through here, the light beam will not be broken or distorted. Okay. As compared to a lesion that is raised, when you pass through the light beam, it will become like this. Curvature. It's curved up. Okay. That is how you use the slit. Most of the time you use the round light beam lah. Okay. Boleh. So our direct ophthalmoscope, the advantage is it is portable. Okay. And then how to say it is the image is upright. Upright means what you see up is up, down is down, left is left, right is right. As compared to we use the binocular indirect ophthalmoscope BIO the one we wear like this one. That one whatever you see is the balik one. What you see up is actually down. What you see right is actually left. Okay. So you need to have a mind that can the balik everything. Okay. This battery power or can charge. Okay, and then it's cheaper as compared to the BIO. Okay, cheaper. Okay, this one usually less than 1,000. The BIO usually 20,000. Okay. Then what is the disadvantage? Also another advantage is the magnification is very large. Large magnification. Okay. Okay. But the disadvantage is the field of view is very small. Field of view. Usually like 5 degrees. Okay, 5 degrees. Okay. Then the distance in between you and patient very near. Usually 10 cm or lesser. Okay. Boleh Usually like that And you have to tilt around to see the whole image. That is the main problem. Okay. So how we want to check? First, you adjust this first. Adjust the refractive status. Okay. For example, I'm myopic. Okay, I'm high myop. I'm 650, or what we call is minus 6.5 diopter. Okay. If you want to wear the glasses, it's a full character. Okay, it's all following your preference and no hard and fast rule. No, you adjust to 0. Okay. If you don't like to wear glasses when checking, like me myself, I don't wear glasses, so I just do -7. Remember I said just now red color is myopia. Okay, I just do -7. Why? Because there is no 6.5 inside. Okay, I just do -7.
-7 tu nampak dalam tu. Okay.
Merah is myopia minus. Okay. I just do -7. Then I take off my glasses. Okay, I take off my glasses. Then I examine. This is when you do not know the patient refractive status. Okay, you don't know. No need to care, never mind, because you don't know. Okay, so you just need to adjust to your own only. Okay, let's say you don't want to wear glasses. You know the patient is for example I'm -7 I'm -7. Patient is myopia -4. What power I should adjust to here?
+4.
The amount -3 -3. What is the power I should adjust to?
Patient -4, you -7. If you nak adjust berapa?
-7.
I tak nak pakai cermin mata.
You tak nak pakai cermin mata.
I tak nak pakai cermin mata.
Okay.
-7. Patient -4.
Mhm.
So -7 -4.
Nak adjust apa?
+3. -3.
It's a simple mathematic algebraic addition je. The
-7
summation
plus
both of them
-4.
just like a simple mathematic only.
-11.
Tapi sini tak ada 11. Sini after 10 is become 15
10,
terus.
15.
So you adjust to 10 lah.
10.
Either you wear glasses, adjust to 4,
Okay.
or you don't want the glasses, adjust to 10 lah. Okay. 15 is too high, so 10 lah. Okay. Let's say you are -7. You don't want to wear glasses. Patient is hyperopic +4. So
+4.
-7 plus 4.
Jadi
Plus three.
Plus
minus 3.
Minus
Minus
3.
3, sorry.
It's just a simple mathematics only. Okay. Very easy.
Okay.
If you want to wear glasses, then even more simple. Just follow the patient only. Okay. Okay.
Kalau tak tahu patient punya ni, just normal.
If don't know, no need to
Zero.
care anything. Just adjust to your own. Okay. The rules number 1 must adjust to your own. Must be correct.
So,
If not, you'll be
Kalau
haywire.
macam I normal 0 lah.
0.
Okay.
If you're plano, then plano. 0. Okay. So you adjust here. Light beam you select according to what one you want, which one you want. All the while have to keep like this. Okay. Actually, when you are expert AD, you can adjust. You let's say you don't know the refractive status of the patient. You can adjust one when you are checking like this. Because the distance in between you and the patient you already familiarize. You know at this distance I should see already, but how come I still cannot see? So you have to adjust lah. Then you know the refractive status of the patient roughly lah. Okay? Roughly. But no need lah. That one no need.
Patient for sure kena remove glasses lah kan doktor?
Yes. For sure. For sure.
Yang kita estimate tu patient punya refractive lah.
But no need lah. That one no need. That one no need. There is need a lot of experience one. No need. Okay. I don't do that usually because we don't usually do this. We usually use BIO or slit lamp faster. The field of view very big. Okay. And then how you want to check? Must remember ask the patient to sit, look far. Don't want to look at your light don't want to induce accommodation and meiosis. Okay. Ask the patient to look far. You can either sit or stand Usually I prefer to stand. What I do, I usually stand at the side of the patient. I open up my stance so that I can stand more stable. Because you have to bend on. You stand like this, when you bend very not stable. Like that. So you have to open up your stance so that you can stand more stable. Okay? And you don't need to bend so much. Okay? Must remember, this is a red flag. When you want to check the patient left eye, it's your left hand and your left eye cannot change anything. Left and right. In the exam, you got anything the balik red flag, straight fail. Okay? Because you don't follow this, you kiss the patient. Okay? So you must follow this. Okay? Ask the patient to look far. Stand at the side of the patient. Number 1, you have to look through, okay, and see the red reflex. The red reflex first, okay. Red reflex is about 1 arm length okay. Then when you see the red reflex, you go in following the red reflex. Then easier for you. Okay. Usually what I do, this hand either you can, if stand gentle, you can put on shoulder, put on stable. If cannot also, you can help to elevate the eyelid. Okay. But you have to remember, if you want to elevate the eyelid, on and off you have to close the eye to help thing, not dry eye. Okay? Very uncomfortable. So here, go in is what is big one. Okay. And you go in. When I go in, someday I go in, someday I will come out. You know I don't touch it. Okay, I turn like this. Okay. Usually the distance is very near, usually 10 cm or lesser. So before that, you have to tell the patient what we will do and what they can expect. If not, suddenly go so near, not comfortable lah. And very important, if it is opposite gender, please get a chaperone. Okay.
Dengar tu hidau.
So when you see the angle that I go in is about 15 to 18 degrees away because the first structure we want to see is optic. This. Okay. Because there is no photoreceptor, this is the most not so uncomfortable impact. Because no receptor, no photoreceptor. Okay. Just now I say it's about 15 to 18 degrees away. So you come from the this center, you come here. 15 to 18 degrees away and muscle. Okay. Boleh?
15 to 18.
Can
Okay.
When
Nak
you
kena
see
imagine
the
the degree.
optics already, you have to tilt around because the field of view is very small. You won't be able to see the whole optics in one glance in all cases. Not so. Sometimes you can see, sometimes you cannot see. If you cannot see, you have to tilt around. Tilt around to see the whole image. Then you go to the vessels, then you go to the macula. If you want to go to macula, ask the patient to look at your light. Okay? Begini. Okay. Most of the time, what we see is this. You see one image here in the one view. So you have to tilt around to see the whole of this. So you have to have a mind that can do a mapping, yes, jigsaw puzzle in your brain. You get the whole image. Okay, then you move around to see the vessels and see the macula. Okay, let's say this is our branching, vessel branching. Okay, let's say you did not get the obliques in the first glance. Okay, you get here. How do you know when you go out or go down? You have to trace along the vessel, right? In order to get to the obliques, because the obliques is where the vessels come out. Okay, come out or converge lah. Okay, yeah. Because artery go out, vessel come in, the vein come in. Okay, how do you want to trace? Now in your first shining there, you see the vessels. You fall on the vessels. No, not like that. How do you know?
Dia punya
Curvature of the vessel.
No. Curvature also can, but sometimes not so.
Diameter.
Okay, one is you can follow the size diameter, but that one very difficult. That one follow experience. Are there easier way or not? Of course lah, the artery the further it is, the smaller it is. Okay, but not so easy. How do you know?
Just go through to each.
Branching. Direction of the
Yes,
branch.
direction of the branching. Okay, this is the obliques. Come here, branching. So basically, it's telling the direction again this way. Imagine this is the arrow. This is the arrow. Okay. So they are telling you this way. So you trace up. Okay. So when you see the obliques, you have to see the color. Margin. Color is pink or not, pale or not? Pink, pale. Okay, margin is well defined, blurred, swollen. Okay. Then you will see the
ratio.
up to this ratio. Okay, this is the
This.
So cup to this. Okay, so you have to have a mind that can do an imaginary line here and divide into 10 segments. 10 segments, 10 segments, I don't know how many segments here. So how many segments taken up by the cup is the ratio lah. Let's say 10 segments here, you take up 3, so it's 0.3. Cup to this ratio is CDR. Okay, like that. So you look at the color of the disc, margin, whether it's raised, is well blurred, is well defined. Okay, cup to this ratio, how much? Okay, and then glaucomatous changes like there is a thinning of the neuroretinal rim, bayoneting, okay, laminar dot sign, all these are glaucoma, these changes. Okay, nasalization of the vessels. Okay, then how do you know whether it is a vein or it is artery? Okay, so vein versus artery. Vein is larger. Artery is 2/3 of the size of the vein. Yes, another is the color. Artery because it's full of oxygen, so it's bright red. Bright red. So it's dark red. Okay, and the wall is thicker. Thicker wall. Okay, properly. Yeah.
Ni kan naik atas sikit.
Artery wall is thicker. Okay, the wall is thinner in vein. Boleh? Yeah, this is how you do like that. So next picture. Okay, so what's the problem we encounter? Oh, sorry, before that. When you want to see around the other parts you have to tilt you cannot move left right you can't when once the light come out you lost your direction. So you are tilting around inside a viewing window, it's tilting around. Okay. So what's the problem we encounter? Number one, you don't know anything. That is very common because you don't know where you see. Okay. Number one, cannot don't know, cannot don't recognize. Okay. That one comes with experience. So usually what I ask my medical students do, Google the image first. Okay. Okay, then after that
Uncooperative patient.
yes, uncooperative patient. Uncooperative. That one can't do much lah. And then you did not see anything. This one you have to make sure did not see anything. This one, the alignment correct or not? Alignment. Okay? Alignment. Because patient looking like this. Looking like this, right? If your light beam is coming here, how you want to hit? You have to come this way. Okay? Same plane. Alignment correct or not? Okay? Then the pupil size and shape, the light beam size. Light beam size. Correct or not? Then you have to do like that lah. Okay? And then what other problem usually?
Kalau dekat KK kan, kita tak boleh buat fundus because kita tak ada dilator. So some patient very constricted pupil, very small pupil.
Okay, that one come with practice. You adjust to the smallest one. Adjust to the smallest one and try to go to a dark room and see through. Basically, if you are able to see the obliquities and macula is very good already lah. Okay. Usually like that lah. You have to practice lah, no choice.
Sebab KK, most of the KK ada fundus camera. So we
Okay.
really use
Lagi bagus. You can see the whole image.
Fundus kamera kena suruh dia segi buka dulu. Biasa lambat sikit nak buka tu.
Very good lah. For example not every cases is emergency What you want to see, for example, you're suspecting some SOL. You want to see optic swelling, okay. And then, for example, you're suspecting a CRAO, central retinal artery occlusion. You want to see a Cherrier spot. In a CRVO, you want to see all the vessels dilated tortuous with a lot of fracture hemorrhages, cotton wool spot. Otherwise, I don't think any urgent things you can. You will have to see in the fundus. Okay. For example, SOL, if there's a SOL, you see optic swelling. If you're telling patients, if you're telling others it's a papillary edema, you are telling patient there's a optic swelling secondary to high ICP, SOL or not, okay. So papillary edema is not a word that you can super hardly use. Optic swelling is a large family. Papillary edema is one member of them. Okay. For example, the patient has optic neuritis For example, optic neuritis the optic is swollen okay. But it is not because of the SOL Patient no SOL, no high ICP, but optic swelling. Okay. If you tell others it's a papillary edema, they are directly you think all this ICP related. Okay. Boleh Okay. Any question? This one memang have to practice one
Betul, our ni apa tu, kita tak ada yang slot untuk apa tu, the fundus punya ni.
Tak ada, sebab medical student tak ada kali ni.
Oh.
Kalau ada boleh. Sebab kena bayar SPU RM1.
Untuk dia orang ada yang terlibat dengan fundus punya. Tak, satu lagi kalau fundus interpretation turut tu boleh ni tak? Nak belajar untuk funduscopy, how do we apa tu, guna funduscopy tu nak decide those papilledema semua tu. Finding.
Tengok fundus lah. Ini nak nama satu
for us to interpret the fundus finding.
For you to interpret the fundus finding. You want to know how a top hemorrhage
satu lagi they buat semua.
Google lah, Google.
Google juga.
Google je.
Okay. I memang sebenarnya Google je tapi macam
Google saja.
pasal CPG tu ada juga kan. CPG.
CPG
DR you have to follow your
dia
CPG.
petik ready peti.
Because that is the most common thing you will see in your clinic. Most common thing is DR.
Okay.
You don't have other machine also, right? Your fundus camera, OCT mesti tak ada.
Tak ada.
Tak ada fundus
Tak ada.
camera saja.
Ni.
Bukan klinik KK saja. Ni kadang-kadang hospital yang ada Ofka pun tak ada OCT. Okay?
Tahu kat mana dah KK. Hilang,
Ada-
semua hilang.
Mesti ada dalam laci.
Hilang. So, since we order fundus camera.